Hello, respected judges. Thank you for giving us the opportunity to present our case report, Rectal Fidaxomicin as Salvage Therapy in Fulminant Clostridioides difficile infection after total colectomy. Clostridioides difficile infection is a common and potentially life-threatening cause of antibiotic-associated diarrhea and colitis. It can manifest anywhere from mild to moderate diarrhea to fulminant colitis with toxic megacolon and bowel perforation. The updated guidelines from 2021 by IDSA and SHIA recommend the use of oral vancomycin and IV metronidazole for FCDI. They also recommend using rectal vancomycin in the presence of ileus for fulminant CDI. Although the use of fidaxomicin has been recommended for initial and recurrent CDI episodes, it is not yet recommended or studied in detail for use in fulminant CDI. We hereby present a unique case of a 79-year-old male who developed symptoms of abdominal pain, diarrhea, nausea, and vomiting after using amoxicillin and clavulanic acid for a week. He presented with hypotension, tachycardia, significant leukocytosis, abnormal electrolytes, and acute kidney injury. On imaging, he was found to have diffuse colitis with possible toxic megacolon, with stool studies positive for C. difficile. He was diagnosed with septic shock likely secondary to Clostridioides difficile infection and was started on vasopressors and renal replacement therapy. He was also treated with oral vancomycin and metronidazole and eventually started on rectal vancomycin per recommended guidelines. He subsequently underwent total colectomy and was continued on the same medication without any improvement. Eventually, he was started on rectal fidaxomicin along with loperamide for symptomatic management. He was soon taken off vasopressor support and renal replacement therapy with improving WBC counts and creatinine levels and was discharged to a long-term care facility in stable condition. We are introducing a novel method of using rectal fidaxomicin for the treatment of fulminant CDI, which has rarely been described in literature. This formulation was composed with the collaboration of our infectious disease specialists and critical care pharmacists who used 1 tablet of 200 milligrams fidaxomicin with 100 milliliters of normal saline, an amber prescription bottle, and martin and pestle to prepare this rectal enema. Using this formulation for 10 days improved our patient's condition dramatically. We also used loperamide for the patient to reduce intestinal motility and to manage high output from the ileostomy. These measures successfully helped our patient to be weaned off vasopressors and renal replacement therapy. Rectal fidaxomicin is a promising treatment for fulminant CDI. On review of literature, we found one case of local fidaxomicin use to the oral part of the sigmoid colon and another case of use of local fidaxomicin on mucus fistula after total colectomy, both of which proved to be beneficial for these patients. We therefore recommend further studies on rectal fidaxomicin for fulminant CDI and its inclusion in treatment guidelines. This novel method can be a promising finding for treatment of FCDI. Thank you.